Clive, do you mind just sharing your slides if you're ready? Can everyone hear me? Clive, are you there?
Yeah, sorry, I'm just getting my slides open. Hold on. There we go. Okay. That's the full screen. Good. Let me know when I can start, Sam.
You can start. Thanks, Clive.
All right. Good morning, everybody. Welcome to this morning's webinar. My name is Cleve Oppel. Sam introduced me, one of the registrars at Paratesticular, and today I'll be talking about Paratesticular rhabdomyosarcomas. And I just want to extend a good luck to all the exam candidates writing today. I hope it goes well. I'm sure none of them will be tuned in. So looking at rhabdomyosarcoma as a tumor in general, before we touch on the paratesticular bit, it accounts for about 15% of all childhood solid tumors, and is the third most common seen in children after Wilms and neuroblastoma. It's the most common of the soft tissue sarcomas, and with regards to urology, it's the second most common tumor we see in our pediatric patients after Wilms tumor. The tumor generally has a bimodal sort of age distribution with peaks under 2 years and over 10 years, but more than 2/3 of these tumors occur in kids under the age of 6. And then with regards to distribution, most commonly seen in the pharyngeal areas such as the head and the neck. And then with regards to urology, it's quite a few which encounters in the bladder and prostate, but the least actually occurs in the paratesticular area. Not really something which really changes anything, but there are some genetic predispositions to these cancers. Patients with Lee-Fraumeni syndrome by the age of 30 are known to have a 50% overall cancer risk, not just for sarcomas, but with regards to sarcomas, about 20 of these will be a sarcoma. In patients with neurofibromatosis type 1, they have a 20 times higher lifetime risk of getting rhabdomyosarcoma than the general population. And then indeed with patients with Costello syndrome, it's now guideline approved that these patients need screening every year or so, as 15% will develop rhabdomyosarcoma. Looking at the pathology, the embryonal rhabdomyosarcoma is the most common sort of subtype which we get, accounting for almost 2/3 of the cases. And then under these, you get your botryoid, which under a microscope will appear like a cluster of grapes. And these are known to arise in hollow organs such as our bladders. Spindle cell is another subtype, and it's most commonly seen in paratesticular, and then anaplastic, which is seen in our trunk and extremities. The latest WHO guidelines ever put spindle cell embryonal as a separate sort of subtype, so not under embryonal, but as a subtype on its own. Alveolar is the next most common, but it's got a worse prognosis and it's known to metastasize more frequently. One thing of note of importance with alveolar subtype is the molecular genetic analysis. If it's gene positive, these patients are known to have a worse prognosis overall. And what makes alveolar as a subtype poor prognostic is the fact that 80% of these are gene positive. And then the undifferentiated subtype is very rare, but also offers a poor prognosis. So just looking at them in general, embryonal has been historically known to obviously have the best prognosis, but it's actually alveolar subtype, which is gene negative, which offers a longer sort of event-free survival. But the fact that 80% of these alveolar subtypes are gene positive makes them slightly worse than embryonal. Trying to move this tab around, it's blocking my view. Pardon me. Okay. So how do they present? I'm just going to quickly touch on the urological ones. So the bladder and the prostate, as you can imagine, like any mass in the bladder, will present with features of sort of irritative LUTs frequency. They can have hematuria. If it's a large tumor at the bladder neck, it can cause obstruction. In small children, the tumor may be palpable, and rarely will this tumor actually prolapse into the urethra. What they do say is that with anyone with hematuria,
sorry, Cleve, your slides are not moving.
Are they not moving?
Yeah, you're actually not in your PowerPoint, so we can't see it actually.
It's still not going at all, eh?
No,
Nothing.
it's not.
Okay, let me stop sharing and then reshare quickly. Here. And about now?
Yeah, just maximize.
Pardon me?
Just maximize the screen, please. Sort of like put on full screen and.
Okay. Is it working?
Well, just move your slides. Just want to see if they're moving.
I'm moving them.
They are not moving.
Okay, let me stop again. Still nothing.
Move? No, not moving.
So was the first few working?
No.
From the beginning, it wasn't working.
No, we just saw that. Yeah, nothing works.
So from the beginning. And now, as you see this.
Yeah.
And then this goes.
No.
That doesn't make sense.
Just move the slides.
I'm doing it.
Yeah.
Okay.
Yeah. Sorry, Cleve. I mean, I think it's a very, very important topic, and I was actually a bit frustrated when nothing was happening.
Yeah.
Is it okay if we start from the beginning? I don't know if
yeah.
That.
If everybody's fine, yeah, I can just run through. So it's definitely playing nice, eh?
Yeah, it's going very well.
Okay. So as I just said, we're just talking about paratesticular rhabdomyosarcoma this morning, but I'm just briefly going to touch on rhabdomyosarcoma in general prior to jumping into the paratesticular sort of stuff on its own. We mentioned it's a very common tumor, the third most common tumor in kids seen after Wilms and neuroblastoma. And with regards to urology, it's the second most common tumor that we encounter in pediatric population after Wilms tumor. Age distribution wise, more than about 2/3 occur under the age of 6. So there are 2 peaks, but more than 2/3 of this tumor occur before the age of 6. And the most common place that you actually find these are the parameninges, so the head and the neck. But with regards to us in urology, bladder and prostate is a lot more common, and paratesticular is actually quite rare. I'm not going to really go into there are certain genes which are patients are more genetics in which patients are more at risk of developing tumors in general, and of those rhabdomyosarcomas some. You just need to be aware of some of these. Some of these actually require screening in the future. The subtypes, this is actually quite important. So the embryonal subtype is the most important and the most common one. It's actually known to have the best prognosis, and there are subtypes under that, of which botryoid microscopically looks like a cluster of grapes, and that's the one that you get in the bladder more commonly. And spindle cell is actually the one which commonly more occurs in our paratesticular patients. Then with regards to alveolar, it's the second most common, and it has been historically deemed to have a much more worse prognosis than embryonal. And that sort of recently molecular genetics has shown us that is because there's different subtypes of alveolar, and those that are fusion gene positive, PAX3 and PAX7 positive, they have a very poor prognosis, and they make up 80% of alveolar. And then undifferentiated, which is least common poor prognosis. So if you look at this again, yeah, those alveolar subtypes that are actually fusion negative have a better overall prognosis than embryonal, but because so many of them are fusion positive, they don't do well. How these rhabdos sort of present in the urology setting with the bladder and the prostate, the patient will have a bladder mass. So they will have irritated sort of LUTs, they can have hematuria. In small children, the tumor can be palpable and it really actually prolapses into the urethra, but it has been reported. So any patient with, especially a child with hematuria, you would start with an ultrasound, obviously because radiation is the least invasive. But then most of the textbooks say definitive imaging needs to be followed up after that in the form of CT or an MRI. Similar to paratesticular, these actually present just like a testicular cancer, unilateral, firm, painless mass. Ultrasound will show a hyperechoic heterogeneous solid lesion. And then again, the textbooks normally say a CT needs to follow after that. So of late, a lot of studies are now moving, saying to move away from CT. This was an article, I think it came out in 2015 by Eugene and colleagues, which basically want to compare PET-CT against the conventional imaging modalities for two parts of rhabdos. They wanted to see how PET compares to conventional imaging when initially staging these patients and when assessing their response to chemotherapy. So they had about 23 patients in their study, aged from 9 months to 21 years old. And what they found was that the PET-CT was superior to conventional imaging modalities. So conventional imaging modalities is CT, MRI, and bone scan. And PET was superior to all of these with regards to determination of lymph node involvement at 100% sensitivity, and detection of METs at was 100% sensitive here again. They found that when looking at tumor response, 69% of patients underwent PET-CT actually indeed had a complete response to the chemo, whereas only 8% of those which had sort of bone scans for follow-up had a complete response. And this actually changed the therapeutic management of these patients in 13% of them going forward. So they said that PET reveals important additional information when staging, and that suggests a superior prognostic value over conventional modalities. So it's because of sort of studies like that last year's European guidelines, especially for pediatric radiology, has now incorporated PET. So they say when initially staging and screening and initially staging a patient, MRI is actually recommended, but for looking for local regional nodes or METs, PET-CT or PET-MRI is now recommended. So the staging itself of rhabdomyosarcoma is quite tricky and can confuse a lot of people. So it's basically you get your TNM staging and your clinical grouping, and then from there you can risk stratify these people. So if you look at the intergroup rhabdomyosarcoma study group, they look at the TNM and whether it's favorable or unfavorable. So the only unfavorable rhabdo is actually location, which is the bladder and the prostate. So fortunately, paratesticular is actually a favorable location. And then it would be sort of any TNM stage with stage 4 being metastases. After that, you get your clinical group assignment. And this looks at tumor bulk or residual tumor after doing an initial resection. So if you're going to do a radical orchi for paratesticular rhabdo, it looks at what's left over. So group 1 would be tumors completely gone. Group 2, there's still microscopic residual disease after you thought you cleared everything. With group 3, you know you left tumor behind. It was quite a large tumor bulk. And group 4 is distal metastasis. Only once you've got all of these can you now sort of risk stratify the patients. And you can see, looking at this slide here, put them into low, intermediate, high risk. There's a lot of, they look at stage, they look at clinical group, they look at patient histology. It's quite confusing. But the takeaway from there is probably just to remember that any tumor which is greater than 5 centimeters is poor prognostic. Patients over the age of 10, if they have a clinical group of 3, so they got large tumors which you can't completely resect, and if they got nodal involvement, that's actually poor prognosis. So we're going to delve into a case which we recently kind of flew to ski. This is a 17-year-old boy. He was previously well no chronic illnesses, and he presented us with a 4-month history of abdominal pain. He had loss of weight. He had a left scrotal swelling and a left flank mass. On examination, he appeared a bit pale and he had a palpable virtuotrocea node. His abdomen had a left abdominal mass which was not volatible, and he had a massively enlarged left sort of hemiscrotum and a thickened cord. Immediately we thought, based on his age, this was in keeping with a testicular cancer. However, he had normal serum beta HCG and alpha fetoprotein. He had elevated LDH. He had a slight acute kidney injury as well with creatinine 117. So we sent him the CT, which showed a large left testicular mass, which was reported as a left testicular mass. These are some stills. As you can see here, there's also quite a large amount of retroperitoneal lymphadenopathy, which is indeed causing obstruction of that left kidney, which could explain the acute kidney injury. Looking at his chest, as you can see here, there's a large amount of pulmonary nodules as well as mediastinal lymphadenopathy. And then this actual view of the CT here just shows sort of the extent of that retroperitoneal lymphadenopathy, how it's encasing his major vessels, causing displacement. So it's quite extensive disease. This patient was taken to theatre for radical orchidectomy and placement of a left deger stent. And to our surprise, the histology came back showing paratesticular embryonal rhabdomyosarcoma, a large tumor with positive margins at the cord. So he was assessed to be a grade clinical group 4 based on his pulmonary metastases. This gentleman, as you can imagine, had a lot of poor prognostic features. He was older than 10, primary tumors larger than 5 centimeters, clinical group higher than grade 4, and definitely had nodal involvement on his imaging. So when looking at paratesticular rhabdomyosarcoma as a subgroup of rhabdo, as comprises only 7% of all genitourinary kidneys. It's paratesticular because these tumors come from the epididymis, spermatic cord, and the tunnix. And the disease, again, like most rhabdomyosarcomas, keeps in with the bimodal age distribution, with peaks in paratesticular before 6 and after the age of 14. Again, a CT scan is indicated in all patients to evaluate the retroperitoneum, but hopefully this will now move towards PET CT going forward. The prognosis for these tumors is generally favorable, and that's because about up to 80% of them are quite early stage, in stage 1 when they're first detected. The majority of these are embryonal subtype, and total resection can often be achieved upfront. Looking at the study regarding localized paratesticular rhabdomyosarcoma, this was quite a large study produced in 2018, and they looked at involved a lot of centers from North America and Europe. They wanted to look at what sort of variables affect the patient's event-free survival and overall survival. A large number of patients here, 842 patients, and they found that in boys under 10, most tumors are smaller, so up to 75% under 5 centimeters. Most tumors are completely resected and indeed stage 1 at the time of diagnosis. And more than 90% of these kids under 10 had no lymph nodes in the retroperitoneum, no clinical involvement. Whereas those over 10, a lot more had tumors which were larger, a lot more had positive margins after resection, microscopically positive, and almost 20% had clinical lymph node involvement, which is quite a lot. So the conclusion overall, the tumors got an excellent outcome with 5-year event-free survival and overall survival in the 80s and 90s. But as we mentioned, poor prognostic factor is age, which can really make that decline. Looking at, so not localized, but metastatic rhabdomyosarcoma, I couldn't find an article specifically pertaining to paratesticular metastatic rhabdomyosarcoma, but in general with metastatic rhabdomyosarcoma, the intergroup rhabdomyosarcoma study group has released quite a few study reports and have been sort of the leaders in the staging and the guidelines. This study wanted to look at which risk factors associated in these kids would influence their outcome in kids that have metastatic rhabdomyosarcoma. At 127 patients in the study were treated with chemo, and the study endpoints were failure-free survival and overall survival. And what they looked at, what would influence the failure-free and overall survival in metastatic setting, they wanted to see if age, the histology, the site of the primary, and the number of Mets would influence those factors. And what they found was overall, for all kids with metastatic rhabdomyosarcoma, the overall survival and failure-free survival 3 years was 39% and 25% respectively. Overall survival was significantly influenced by histology and increasing number of metastatic sites. And that the combination of embryonal histology and 2 or fewer metastatic sites actually had okay or better outcome than expected, with 3-year overall survival up to 47% and failure-free survival up to 40%. So it does make a difference where they metastasize to and what the histology is. So back to paratesticular rhabdo and the management. So upfront, every patient will get a radical orchidectomy, proximal, get the cord as close to inguinal ring as you can. All patients over the age of 10 need to be offered an ipsilateral nerve-spreading retroperitoneal lymph node dissection. The only caveats to this are kids under 10 who are clinical stage 1 who do not have any nodes in CT. This is the only subgroup in which you do not require to perform a retroperitoneal lymph node dissection. Thereafter, patients will be offered adjuvant chemo and maybe RT, and that all depends on what you find at your lymph node dissection. So if they're lymph node positive, you give them BAC and RT. If lymph node negative, just vincristine and actinomycin. So the guidelines regarding the lymph nodes and who to offer lymph node dissection to and when to offer lymph node dissection to are constantly changing. In Europe, the INSTRUCT group is a combination of the Children's Oncology group, the European Pediatric Soft Tissue Sarcoma group, and then a German group, which I can't pronounce that name. but or I struggle to. But they look at their latest guidelines with regards to lymph nodes, say that nodes greater than 1 centimeter on imaging should be biopsied. And if you're not going to biopsy the node or do a dissection of that node, that should be presumed to be positive and therefore group 3. And the patient should then be treated according to the chemo regimen or the adjuvant therapy regimen as per group 3 fashion. All patients over 10 should undergo nerve-sparing retroperitoneal lymph node dissection to identify those that have pathological disease. And that's based on the study. I forgot the name of the group, pardon me, but essentially what they showed is that compared to in children with patients with N0 disease, those over 10 had 31% nodal recurrence when they were deemed to be N0, whereas those under 10 only had about 8% nodal recurrence when deemed to be N0. So age was a significant factor. There are templates available. They use the standard retroperitoneal lymph node dissection template, but adequate template would have about, or dissection would have about 7 to 12 nodes in it. And then I think the important thing to remember regarding the retroperitoneal lymph node dissection here is that unlike testis cancer, where we need to clear the retroperitoneum to sort of change this patient's outcome, these are sarcomas, so they're predominantly treated with chemo. So the idea behind retroperitoneal lymph node dissection with paratesticular rhabdomyosarcomas is not a clearance operation like in general testis cancer, but it's more sampling to help us stage these patients. Indeed, the INSTRUCT group, the COG, and the European Pediatric Sarcoma group do not, after performing chemo, do not go and perform a secondary retroperitoneal lymph node dissection, whereas the German group is unsure and they actually do advocate for performing retroperitoneal lymph node dissection if the patient still has persistent lymphadenopathy. This sort of quote from the experience of the Italian cooperative group applies to actually the primary and the nodal disease, and they say there's little evidence that debulking surgery will improve outcomes compared with biopsy alone, and therefore debulking surgery is actually not recommended upfront for patients with rhabdomyosarcomas with large tumor bulk. So back to our case, our patient, 17, young guy with stage 4 embryonal paratesticular rhabdomyosarcoma, was started on chemotherapy. But sort of what to do next with this patient? How do we image him? Do we go back into the peritoneum? There are guidelines saying do, guidelines saying don't. So if you look at what the INSTRUCT group says, they say in these patients or all patients with advanced tumor, you use multi-drug chemotherapy in 3-week cycle. Induction lasts for about 9 of these 3-week cycles, and then after about the 4th course or the 6th course, you would offer the patient radiotherapy or surgery, and that depends on whether the disease is localized or has mets. In terms of imaging, they recommend assessing the initial response after about the 2nd or 3rd course of chemo, so you perform CT then, and then to reassess the disease status just before you plan on performing any further surgery. So this is just a summary of sort of the guidelines on when to screen during induction phase and maintenance therapy chemo, and what imaging to do, CTs or PET. So if you look at our patient, we performed repeat imaging on him after 6 cycles of chemo because he was metastatic. And looking at these stills, the before and after, there was definitely improvement in the amount of pulmonary nodules as well as the mediastinal lymphadenopathy. And then looking at his retroperitoneum as well, he still had quite significant, it was a significant improvement as well in the bulk of the retroperitoneal lymphadenopathy. But the question is, and one of the questions with rhabdomyosarcoma is that still active tumor, because that will then influence the duration of your adjuvant chemotherapy as well. What this could be is it could be rhabdomyoblasts, which studies have shown do not need any sort of further intervention as opposed to active tumor does. Another issue with our case is that the bulk was still causing sort of occlusion of his ureter. So it was quite essential for us to know if he still had ongoing cancer in that area. So as I mentioned, part of the INSTRUCT group, when performing a secondary retroperitoneal lymph node dissection, the German group was the one that actually advocates for performing retroperitoneal lymph node dissection when there's still residual nodes after putting a patient adjuvant chemo. And basically what they say is that retroperitoneal lymphadenopathy is quite common in patients older than 10, and optimal treatment, and that's true, is still sort of unknown. So they looked at 4 of their own prospective trials. in patients with paratesticular rhabdomyosarcoma, and they went that sort of involved 147 patients. And in general, what they found in their studies was comparative with the COG essentially was that the overall survival for localized embryonal paratesticular rhabdomyosarcoma was good, as well as the event-free survival in the 90s. But they did perform secondary retroperitoneal lymph node dissection in about 32 of their patients. A quarter of those were found to have viable tumor, and you can see that the event-free survival then drops to about 50% when viable tumor is found. So their conclusion was that it might not always be necessary, but patients with positive lymph nodes, after having performed a secondary dissection, were shown to have a lot more poor prognosis, and then would require additional sort of chemotherapy and radiation therapy. Our patient was taken to theatre for this reason essentially as well, to establish whether they still had active cancer going on there and whether we could clear that sort of retroperitoneal, get them stent-free. We found that the tumor was essentially unresectable. Frozen section analysis and formal histology did confirm that it was still active embryonal rhabdomyosarcoma. Looking at rhabdos in general again, the children's oncology group, patients on their treatment register, about 60% of them are deemed as intermediate risk. And what they say is that these patients, so almost 2/3 do not have, are not amenable to performing upfront complete resection of their tumors. And they will therefore have gross residual disease going into any adjuvant chemotherapy program. One question is, again, like our case, how does a response to chemo affect the patient's overall survival? So the study by Lautz and colleagues involved 601 patients with clinical group 3, so quite advanced cancer, were sort of given chemo, and then they looked at tumor response on imaging. So what they did was they classified these into complete responders, in which there was no residual tumor after imaging, partial responders, in which there was still about 50% response, and then stable or no disease, in which there was essentially less than half the tumor bulk was only this fit. And what they found is that 1/3 of these patients don't receive a complete response after going adjuvant chemotherapy, and indeed only have a partial or incomplete response. But even those that did undergo a complete response, so had no tumor after adjuvant therapy, they did not have an actual improved overall survival compared to those that only had a partial response, stating that when the cancer is group 3 or above, the event and overall survival is not as great. Additionally, they also they stated that resection of residual end of therapy masses, so retroperitoneal lymph nodes, was not associated with any survival benefit. So just in closing, what can you offer patients with metastatic rhabdomyosarcoma? Options aren't very, there's not a lot of options available. This study by Klingbeil and colleagues, I think it came out in 2008, looked at high-dose chemo versus oral maintenance therapy in patients with stage 4 soft tissue sarcomas. And a large bulk of those were actually rhabdos. 96 patients, and divided sort of 50-50 almost, who received high-dose chemo and who received oral maintenance therapy. And they found that after a follow-up of almost 5 years, almost 60% of the patients on oral maintenance therapy were actually still alive, which is quite good. And they concluded that oral maintenance therapy seemed to be a promising option for patients with rhabdomyosarcomas like stage 4 cancers. And you can just see by that, by the graph there, that with patients with rhabdos only, the oral maintenance therapy had quite a significant improvement in their sort of event-free survival. So in conclusion, this is a rare tumor, this paratesticular rhabdomyosarcoma, but in general, because a lot of them are localized stage 1 up to 80%, it has a generally favorable prognosis. The management is a paradigm for these patients and involves a cooperation between oncologists, urologists, radiologists, and pathologists from the time of establishing a diagnosis to organizing a therapeutic strategy with chemos and imaging in the future. Upfront for paratesticular rhabdomyosarcoma, radical inguinal orchiectomy is the primary treatment, with RPL&D recommended in all patients older than 10. And then systemic chemotherapy is essential in both early and advanced diseases and has resulted in improved survival outcomes. Thank you. Are there any questions or some chat here?
Yeah, no, thanks a lot, Cleve, for such an excellent overview of a rare and a very interesting topic, as you mentioned. I see there's a question from Dr. Kent Brook.
Yeah, so I'll address that. So yeah, Kent, I think it was one of the earliest slides at the study from 2015, where they compared FDG PET, 18 FDG PET with conventional imaging, so CT, MRI, bone scan, and they compared it with indeed in the initial staging part and with follow-up after sort of about 3 cycles of chemo. And they found that FDG PET actually had 100% sensitivity for detecting nodes and detecting distant metastases, as opposed to 66 and 75% respectively for the CT. So because of that, FDG PET is now included, based on what I read from last year's European guidelines on pediatric radiology. FDG PET is now part of the guidelines for detecting local, regional, or distant meds. So it is included now.
Yeah, thanks. There's a comment from Prof. Lazarus saying FDG PET does have a role in initial diagnosis, but I mean, he is not sure if there's a role in the post-chemo, as we know, for seminomas.
Yeah, so that same study, like if you just see the second last study which we described here, so that same study involving FDG PET also looked divided when assessing a response to chemo, divided patients into complete responders, partial responders, and incomplete responders. Maybe I can just get that slide. But essentially what they found is that whereas conventional imaging assessed about 18% of those patients to be complete responders, or 8, pardon me, FDG PET actually found that they couldn't pick up any sort of residual disease after staging them, after checking their, here we go. So that's the slide here, I think. So when looking at, pardon me, after 3 courses of chemo, the rate of complete response was up almost 70% with FDG PET, and we know that's was found to be a lot more sensitive. Whereas there was a lot of more uncertainty, and complete response was only deemed to be about 8% with the conventional imaging modalities. And because of the discrepancies and how they couldn't see any sort of residual tumor with FDG PET, no active uptake, it actually did change management in patients in that study. And it's actually, I think, based on that study, which is why the guidelines changed for that.
Yeah, no, thanks, Clive. I think you also mentioned that there's still a need for biopsy because it may actually help in deciding how to, further treat the patient, and obviously need for more chemo-rad.
Yeah.
Just a quick clarity. I mean, you're really clearly stipulating that there's a role for RPL&D in patients over the age of 10. Would you still offer that in patients who are clinically node negative on imaging over 10?
Yeah, so the guidelines say you have to, Sam, anyone over 10 needs a template retroperitoneal lymph dissection. As we mentioned, you need about 7 to 12 nodes. And that's because there's a study that showed in patients with node N0 disease on CT, up to 31% of these had disease or relapse in the retroperitoneum over the age of 10. And it's because of that reason that they advocate RPL&D for all kids over 10. In a patient like ours who's got, a tumor which is encasing all the major vessels, lymph nodes, they're encasing all the major vessels, and that bulk, you can't really, that's a clinical diagnosis. So this isn't like testes cancer where you need to clear the retroperitoneum. There we have CT imaging, which is suggestive. So we would start them on adjuvant chemo. You're not gonna, that initial imaging we had of this patient, you can't clear that patient. You can't offer him a RPL&D in a sort of therapeutic sense to clear him in the upfront setting. You need to give him chemo. But in patients with node negative disease, I think that's where the RPL&D is most important. It's more of it's a staging diagnostic measure, and not that's the idea behind that thing.
Yeah, no, absolutely. Yeah, you're quite right. I've actually seen figures that are up to 50% recurrence of nodes. Yeah. So, I was involved in that surgery. Like I said, it was more for debulking irresectable. We left some clips so that the guys can be able to sort of direct their RT. Funny enough, there was a distant node which was negative, but the actual tumor massive node, which is negative, but actual chemo and repeated for the section is positive.
Yeah.
Yeah. You get a question from Dr. Cook?
Yeah, morning, Cleve. So it just pertains back to this discussion, and obviously it's not specific to this case, but the reason I asked that very question was because of your slide, and one would think that if the FDG PET is so sensitive and is negative post chemo, then perhaps one could then, save this patient retroperitoneal lymph node dissection. That was my thinking, not this specific patient, but in general, because I think the initial data is all based on, like you said, on CT scan. I mean, those patients that are offered retroperitoneal lymph node dissection. So I would think if this is indeed true that the PET CT is so sensitive, the FDG PET at least, then perhaps one could save this patient RPLND, or a patient RPLND post chemo.
Yeah. So it's very valid. Like I mentioned, that Instruct group from Europe, which consists of 3 sort of major European sarcoma associations, including the COG one. 2 of those 3 don't recommend any form of RPLND after chemo. They say sort of just follow the patient up with imaging, and now obviously FDG PET, because a lot of that stuff will actually be rhabdomyoblast. But that German group actually advocates for performing RPLND. There was a base study which showed a quarter of these patients that have active or large nodes in the retroperitoneum, a quarter of them had active cancer. So that's sort of, for me, the area where it's still a bit tricky. Do you just treat based on the imaging? Do you actually, or do you go in there? I think what we did with our case is we at least have proof that there is active cancer. If we saw this large sort of bulk of tumor, and the biopsies and the resection which was done came back showing rhabdomyoblast, then the books say you don't need to treat that. Can sort of observe those guys. But the fact that he's got active chemo still in that retroperitoneum means that he does need ongoing chemo and indeed RT. So I think that's sort of the role there. I don't think it's a sort of hero move to try and clear everything there. I think it's just to get a diagnosis essentially. But hopefully PET CT can help with that, so that you don't even have to maybe take them. They see active disease on a PET.
Yeah, no, it sounds like the role is not really well defined in post chemo. It's not clearly yet, but promising from what you're saying. So Professor, just want to find out, do you know what the plans are for the same patient? I'm not quite sure if you know, Cliff. Do you know what the plans are for the same patient? I grabbed
his folder. I saw he's still getting adjuvant chemo, and he is going to be for RT. I think his performance and that sort of thing is fine. I think in terms of he was experiencing quite a few. He was getting sort of neutropenic side effects from his chemo. I think like neutropenic sepsis, and he had some quite adverse effects from his chemo. But as far as from what I gathered from his folder was that he was going to carry on with chemo and then be offered RT for that nodal mass, which we couldn't clear surgically.
Sure, thank you so much. It's really a very interesting and exciting talking conversations. Unfortunately, I have to move on to the next speaker. Thanks a lot, Cleve. Excellent job.
Thanks, Sam.
Dr. Manata, you can just share your first slide, please.